Welcome back to the deep dive. Today we are opening a file on a subject that I think everyone thinks they know. But the reality is just, it's vastly different from the cultural shorthand. We're talking about schizophrenia. And if I stop 10 people on the street right now and ask them what that word means, 9 of them would probably say split personality.
Oh, absolutely. Guaranteed. That is, without a doubt, the most persistent myth in mental health. You see it in movies, you see it in casual conversation, but medically speaking, it's completely wrong. Schizophrenia is not dissociative identity disorder. It's not Jekyll and Hyde.
Okay, so if we're wiping the slate clean of the Hollywood version, what are we actually looking at?
We're looking at a biological reality. The mission for this deep dive is to really decode the spectrum. We aren't just looking at schizophrenia as some singular, scary label. We're going to look at the anatomy of the disorder, the neurobiology, the chemical misfires, and the specific diagnostic criteria from the DSM-V. And to keep this from getting too abstract, we're going to follow the case of a young man named Eric.
I think anchoring this in a real profile is crucial because the statistics are really significant. We're talking about roughly 1% of the population. Now, that sounds small until you actually do the math. That's millions of people.
Exactly. And the most heartbreaking statistic isn't even the prevalence, it's the timing. The typical age of onset is between 15 and 25. This is a condition that strikes right when adulthood is just launching.
Which brings us to Eric. So let's open his file. Eric M. He's 18 years old, just started college. By all accounts, a high achiever, steady, reliable, no prior history of trouble. But then he hits the second semester of his freshman year.
And the wheels start to wobble. This is what we call the prodromal phase. It's rarely some, explosion out of nowhere. It's usually a slow slide. Eric starts having trouble concentrating. He's missing classes.
See, and if I'm his parents or his roommate, I'm not thinking psychosis. I'm thinking burnout. Maybe he's partying too much. Maybe the coursework is just too hard. It looks so much like depression or anxiety.
That's the camouflage.
Yeah.
It mimics so many other things. But then the reports change. The school contacts Eric's family because his roommate reports that Eric is talking weird.
Talking weird. I mean, that's a pretty vague distress signal.
It is, but the roommate elaborates. He says Eric is getting derailed. He'll start a sentence about, say, dinner and just swerve into a conspiracy about the internet, then stop. The roommate actually asked him if he was high. Eric said no, and the roommate believed him. There was something else going on.
So we've gone from just academic struggle to completely disjointed communication.
And then comes the suspicion. Eric eventually admits to his parents that he feels something weird is happening. He's distressed. He admits he's suspicious of everyone he passes on campus. He thinks people are watching him.
That paranoia, that seems like the tipping point where you realize this is not just stress. But let's pause on Eric for a moment. The title of this deep dive is Decoding the Spectrum. Is Eric definitely schizophrenic at this point, or is there a gray area here?
Oh, there's a massive gray area. The DSM-V, which is kind of the psychiatrist's rule book, is very, very specific about this. It differentiates these disorders based largely on duration and the specific mix of symptoms. You can't just slap the schizophrenia label on someone because they're having a bad month.
So walk us through that hierarchy. What's the threshold for actual schizophrenia?
To get the formal diagnosis of schizophrenia, you need a continuous disturbance for at least 6 months. And critically, it has to significantly impair your functioning, your work, your school, your relationships. They have to be falling apart.
6 months is a long time if you're in crisis. What if Eric has all these symptoms, the paranoia, the speech issues, but it's only been going on for, say, 3 months?
Then the diagnosis is likely schizophreniform disorder.
Schizophreniform, okay, that sounds like a provisional status.
In a way, it is. The symptoms are identical to schizophrenia, but the key is the duration is less than 6 months. And the interesting thing is that about a third of people with this diagnosis actually recover and do not progress to full schizophrenia.
That's a huge distinction. So there's a chance it's a kind of temporary neurological storm.
Precisely. Then you have something called brief psychotic disorder. That's even shorter. It's a sudden onset of delusions or hallucinations lasting anywhere from 1 day to 1 month, and then poof, a complete return to baseline functioning.
Wow. That sounds incredibly volatile. 1 month of chaos and then you're just back to normal.
It happens, and it's often triggered by extreme stress or trauma. Then, moving across the spectrum, you have schizoaffective disorder. This is a tricky one. Think of it as a hybrid.
A hybrid of what?
Of schizophrenia and a mood disorder. So you have the psychosis, the voices, the delusions, but they occur alongside a major mood episode, like severe mania or major depression.
So it's where bipolar disorder and schizophrenia can overlap.
That's a great way to put it.
And that must be incredibly complex to treat because you're fighting the mood instability and the reality distortion at the same time.
It is. And the final one I'll mention is delusional disorder. This is where the person has a fixed false belief for a month or longer. Say, the government is replacing my mail. But, this is key, their functioning isn't destroyed.
So they don't have the talking weird part, they aren't seeing things.
Right, no hallucinations, no disorganized speech. They might hold down a job, pay their bills, and seem totally normal until you ask them about their mail.
Okay, so back to Eric. He's failing school, he's not making sense, he's suspicious. He's definitely moving toward the heavier end of the spectrum. But I want to know why. We talk about mental health so often as if it's purely in the mind. But is there physical proof? Is Eric's brain different?
This is where the science has gotten really, really sharp.
Yeah.
I mean, we used to blame bad mothers or upbringing. We know now that's absolute nonsense. We have MRI evidence comparing monozygotic twins, identical twins, one healthy, one with schizophrenia.
And since they're identical twins, their DNA is the same. Their brains should, theoretically, look the same.
They should. But in the twin with schizophrenia, the MRI shows something called ventriculomegaly.
Ventriculomegaly. Okay, breaking that down, that means enlarged ventricles.
Yes. The ventricles are the fluid-filled spaces in the center of the brain. In the affected twin, these spaces are significantly larger.
And if the empty space is bigger,
it implies that the actual brain tissue volume is reduced. The gray matter has effectively shrunk, or maybe it didn't develop fully in certain areas. So when we talk about schizophrenia, we are not just talking about a software problem. It is a hardware problem. It's a structural organ disorder.
That is a really powerful reframing. It makes it as physical as, I don't know, a heart defect. But what about the chemistry? We always hear about the chemical imbalance.
Right, the neurochemical soup. The main character here has always been dopamine. For decades, the leading theory has been the dopamine hypothesis, that there is simply too much dopamine activity in certain pathways of the brain.
And that excess dopamine is what drives the paranoia, the sort of overactive reality.
Exactly. The positive symptoms, which we'll get to, are strongly linked to this dopamine overdrive. But it's not just dopamine, it's a complex interplay. You have serotonin, glutamate, acetylcholine, and a really critical one called GABA.
GABA, that's the inhibitory neurotransmitter, right? The one that calms things down.
Correct. Think of GABA as the brain's braking system. It regulates the dopamine firing. In schizophrenia, we see a loss of these GABAergic neurons.
Well, the brakes are cut and the dopamine engine is just revving out of control.
That's the perfect analogy. And you combine that biological setup with environmental triggers. Genetics play a huge role, like we saw with the twins. But environment can pull the trigger. Prenatal stressors, complications at birth.
I noticed in the research it mentioned living in an urban area is a risk factor.
It is. Statistically, schizophrenia is diagnosed more frequently in people who are raised in urban environments. We don't know exactly why. Could be sensory overload, social fragmentation, pollution, but the correlation is there.
And substance abuse.
A major comorbidity. Specifically, nicotine dependence. The rates of smoking in the schizophrenic population are incredibly high, much higher than the general public. There's a theory that they might actually be self-medicating, using nicotine to try and help with cognitive processing.
I want to clarify one thing because this often comes up in social discussions. Does race or culture play a role in who gets this?
The data is very clear on that. No, there is no difference in occurrence related to race or culture. It affects all demographics equally.
Okay, let's get into the actual experience of the disease. We've seen the MRI. We know the dopamine is spiking. What does that look like for Eric? You mentioned positive symptoms earlier.
Right. And this is often where people get confused. In medicine, positive doesn't mean good. It means the presence of something that shouldn't be there. It's something added to reality.
Like the hallucinations.
Exactly. Eric hearing voices is a positive symptom. Auditory hallucinations are the most common, but they could be visual, olfactory smelling things, or even tactile.
Tactile, like feeling things touching you.
Yes. And this brings us back to Eric's file. Later in his assessment, after his parents intervene, Eric tells the nurse, "There are worms under my skin eating the hair follicles."
That is visceral. That is terrifying.
It is. And that is what we call a somatic delusion, a fixed, false belief about the body. To him, that sensation is 100% real. That is a textbook positive symptom.
We also talked about his speech. The roommate said he gets derailed.
That's another positive symptom called associative looseness. The threads of thought they just unravel. It can progress to something called word salad.
Word salad, is that just random gibberish?
To the listener, yes, it's an extreme jumble, blue market skipping stone Tuesday. But to the patient, there might be a connection. They might also use clang association.
Clang association.
It's using words based on their sound rather than their meaning. Like, I need the light, the fight, the bite, the sight.
It sounds almost poetic in a way, but it represents a serious neurological misfire.
Precisely. They might also use neologisms, made-up words that only mean something to them, or echolalia, where they just repeat what you say to them like an echo.
So those are the positive symptoms, the added chaos. But the other side of the coin seems almost the opposite. The negative symptoms.
These are the things that are taken away from the person. We sometimes call them the A-list.
Okay, one is through the A-list.
Anhedonia, the inability to feel pleasure. Avolition, a total loss of motivation. Asociality, affective blunting, where the face becomes a flat mask showing no emotion. And apathy.
You know, hearing that list, anhedonia, lack of motivation, withdrawing socially, that sounds almost indistinguishable from severe depression.
It overlaps heavily, which makes diagnosis so tricky. But these negative symptoms in schizophrenia are often more persistent. And imagine the impact on the family. Eric's parents might see him sitting in a room for hours, staring at a wall, not showering. It's easy to misinterpret that as laziness or just giving up.
But it's actually the disease stripping away his drive.
Exactly. And clinically, these negative symptoms are much, much harder to treat than the voices or the worms. They tend to linger even after the psychosis is managed.
There was a third bucket mentioned in the source material, cognitive symptoms.
This is the executive functioning. The ability to process information. This explains why Eric's grades dropped first. He literally couldn't process the coursework anymore.
Yeah.
But there is one specific cognitive symptom I want to highlight because it changes everything about treatment. It's called anosognosia.
Anosognosia, let's unpack that.
It translates roughly to lack of insight, but it is not denial. Denial is a psychological defense. I don't want to admit I'm sick. Anosognosia is a neurological deficit. The part of the brain responsible for self-reflection and self-concept is damaged by the illness itself.
So Eric physically cannot understand that he is ill.
Correct. His brain is telling him with absolute certainty, I am fine. The problem is everyone else.
It creates an impossible situation for treatment. How do you convince someone to take heavy-duty medication for a disease they physically cannot believe they have?
It is the single biggest hurdle in psychiatry. It's why patients so often stop their meds. I mean, why would you take a pill that gives you side effects for a disease you don't have?
Speaking of pills, let's look at the toolkit. We've come a long way since the asylums of the mid-20th century. What are we using to treat someone like Eric?
We rely on antipsychotics.
Yeah.
And we generally split them into two eras, first generation and second generation. Think of the first generation meds drugs like haloperidol as the sledgehammers.
Sledgehammers. Effective but blunt.
Exactly. They are very good at crushing the positive symptoms. They stop the voices. But they are messy drugs. They have a high risk of what's called EPS, extrapyramidal side effects.
Which are?
Motor control issues, muscle stiffness, agitation, shaking. And the nightmare scenario is something called tardive dyskinesia. Involuntary, repetitive movements of the face or body that can become permanent.
That sounds like a terrifying trade-off, so we developed the second-generation drugs to avoid that.
We did. Drugs like olanzapine or clozapine. Think of these more like, well, maybe not scalpels, but refined tools. They treat both the positive and the negative symptoms, and they have a much lower risk of the shaking and movement disorders.
Okay, sounds like the clear winner.
You'd think so. But there was always a trade-off. These second-generation drugs carry a massive risk of metabolic syndrome.
Weight gain.
Significant weight gain. Diabetes risk. High cholesterol. So if you're Eric, your choice is take a sledgehammer and maybe develop a permanent twitch, or take the scalpel and gain 50 pounds and potentially get diabetes.
That is a brutal choice for anyone, let alone an 18-year-old college student.
And remember, anosognosia. You're asking him to make this physical sacrifice when he doesn't even believe he is sick. This is why adherence, staying on meds, is so incredibly low.
Is that where the injectables come in?
Yes. Long-acting injectables, instead of a daily pill, it's a shot every few weeks or even months. It takes the daily decision-making out of the equation and ensures steady medication levels.
Beyond the chemistry, though, there's the human interaction. If I'm a nurse, or Eric's dad, and he tells me about the worms under his skin. Surely I shouldn't say, yes, I see them.
No, absolutely not. That reinforces the delusion. You don't want to validate the false reality.
But I also can't say, you're crazy, there are no worms, because to him, the pain is real.
Right. If you argue, you lose his trust completely. You have to thread the needle. You acknowledge the distress, not the reality.
So what does that sound like?
It sounds like, I don't see the worms, Eric, but I can see how scared and uncomfortable you are right now. You validate the emotion. You focus on the feeling.
That requires so much patience and empathy.
It does. It's about creating a safe milieu, an environment where he feels safe, where limits are set, but where he isn't being constantly told that his reality is wrong.
So let's look at the timeline for Eric. His
Yeah.
parents came to campus, they got him help. He's in the acute phase right now, the crisis. What does the road ahead look like for him?
We generally see 4 phases.
Yeah.
We had the prodromal, which was the start. We're in the acute phase, the crisis. Now, with treatment, we hope to move to stabilization.
And what does that look like?
The symptoms diminish. The worms go away. The speech clears up. He starts to reconnect with reality. And then finally, we aim for maintenance or residual.
Is that a full cure?
No, it's a new baseline. The goal shifts to preventing relapse and helping him achieve as much independence as possible. But it is so important to tell the listener, recovery is not a straight line.
It's jagged.
Very. And even when the hallucinations stop, the internal cognitive recovery, the healing of the self, that takes months, sometimes years. He has to relearn how to trust his own mind.
Eric's story is really a life interrupted. We've covered the biology, the spectrum of symptoms, the word salad, and the really difficult choices in medication. But as we close this file, what is the one big idea you want people to sit with?
I want to go back to anosognosia. I think it raises a profound ethical question that we really haven't solved.
Yeah.
Well, in our society and in medicine, we value autonomy above almost everything. The right to choose, the right to say no. But here, the organ responsible for making choices, the brain, is the very thing that is broken.
Right.
So if a patient physically cannot know they are sick, how do we ethically navigate treatment? If we force treatment, we're violating their civil liberty. If we don't, we are leaving them trapped in a terrifying false reality.
It's that tension between protection and control.
Exactly. It challenges our fundamental ideas of what it even means to be a self. And it demands a level of empathy that goes way beyond just being nice. It asks us to try and understand a reality that we can't even begin to imagine.
That is a heavy thought to leave on, but a necessary one. It certainly changes how you look at the person you might see muttering to themselves on the subway.
It should.
Thank you so much for guiding us through this spectrum today.
Thanks for having me.
And thank you to everyone listening. We'll see you on the next deep dive.